The following is a presentation on Medicaid expansion by Ryan Hankins, Executive Director of the Public Affairs Research Council of Alabama. It was presented at the Protect Healthcare in Our Community event in Brewton, Alabama on February 27, 2023.
Well, thank you all. Thank you for coming out this evening, and thank you for your interest in this topic. As Chris said, I'm going to talk about the study that we did on Medicaid. Started that in 2021, published it in 2022, and made some revisions late last year, and those are reflected in these numbers that I will share with you this evening. A little bit like ARISE, PARCA is a nonpartisan research organization. Unlike ARISE, we're not advocates. It's great that they are. We need advocates. That's not what we do. Our work is to conduct what we call non-ideological research. By law, every nonprofit is nonpartisan, but you can go to organizations and quickly find out their ideological leanings. We don't have that ideological goal. Our goal is what we call sound policy. So we begin projects in education, in tax policy, in Medicaid, not really sure what we will find. And knowing that folks like ARISE might not like what we find. That's always the risk of working with us, because there are plenty of people who will give you the research you want. That's not what we do. A lawmaker a few years back said to me, I'm right, no, said to me, you know, I don't always like what PARCA says, but I always trust what PARCA says. I think it's pretty high praise. My response was, well, I don't always like what PARCA says. I'm surprised by what we find sometimes. But our focus is nonpartisan, non-ideological research and analysis to help our state and local policymakers, nonprofit leaders, citizens develop policies that are driven by facts. We were founded by former Governor Albert Brewer in the 80s, and it was his goal that we would live into this mission of being the trusted source of research and data. And that is our guide there, the quest for sound policy, which we define as policies that pursue a real issue rather than one that's generated to get votes, that is based in solid research, not hunches or ideology, that pursues a clear goal. Sometimes our policy solutions don't work because the goal, success, is so poorly defined. They're thoughtfully designed, given the tools they need to be implemented, constantly assessed, and constantly revised. So this is sound policy, not left-leaning policy or right-leaning policy. It's not really a political conversation. As mentioned, we're a C3 nonprofit. We don't have state funding. We don't have an auxiliary. We don't have a PAC. We don't lobby or advocate other than explaining our findings, which is tonight Medicaid in Alabama. And I want to start, this is kind of getting ahead of myself on my timer, I think. I'll be speaking quicker. What is Medicaid? I want to start by talking about this, setting the stage of what I mean by Medicaid. Although this has been a top policy priority, at least at the federal level, for going on a decade now, there's still significant confusion about what Medicaid is and what Medicaid is not. That's partly because we hear Medicaid and we think about Medicare. They began at the same time as part of the Johnson administration, the Good Society in the 60s, designed to expand health care to different populations. The major difference, however, is that Medicare is a singular program. Medicare is the same in every state across the entire country. And your Medicare benefits here are the same as they would be if you moved to Texas or Ohio or to Oregon. And once you qualify for Medicare, as far as I know, you don't unqualify for Medicare. Conversely, Medicaid is 51 different programs. The federal government establishes a floor that Medicaid must at least provide these services in each state. You can do more, but you cannot do less. And consequently, the federal government will pay at least half of the cost of Medicaid. My comments right now are about Medicaid as it's always been since 1960 whatever. We're not talking about expansion. This is just the way Medicaid works. That the federal government pays at least half of the Medicaid costs in every state. In Alabama, they pay about 72%. We're, I think, fifth highest in the country in terms of how much our costs are paid by the federal government. The most recent fiscal year, Medicaid served about 1.2 million people in Alabama, about 25% of the population. This is very hard to quantify because unlike Medicare, in Medicaid, you can fall into and out of qualification month by month. It's very tied to income, family situation, other variables. So the state spends a lot of money qualifying and unqualifying and re-qualifying Medicaid enrollment. What this means is that the Medicaid enrollment changes every single day. This number is the max number of people who receive Medicaid at least 1 month in the most recent fiscal year, about 25% of the population. In Alabama, most recipients of Medicaid, that green bar there, are children. 52% of the people covered by Medicaid are those 19 and under. Likewise, Medicaid pays for most births in Alabama. The second chart, the bar chart, tells us that the biggest share of dollars, 46%, go to people with disabilities. That could be adults or children. That could be learning disability. It could be a speech disability. It could be hearing impaired, vision impaired. It could be a range of things. But in Alabama, most recipients are children, and most of the dollars, the largest share of dollars, go to people with disabilities. And then other populations, low-income seniors and what have you. This is different in other states, but this is our Medicaid mix. Here in Escambia County, it's a little bit higher rate, 24.5% statewide. In Escambia, in the most recent year, about 32% of the population received Medicaid at some point in that fiscal year. There have been 1 month, 3, 6, 12, the entire year, but a slightly higher rate of Medicaid coverage, which means the hospitals in Escambia are broadly more dependent upon Medicaid than other hospitals around the state. This is the population breakout. Again, almost identical to the state numbers. About half the population are children, and then other populations reflecting Medicaid coverage here in Escambia County. So most recent fiscal year, our Medicaid bill was $7.133 billion. That's a lot of money. That's 133 and 6 zeros. Lots of money we spend on Medicaid. But again, the federal government pays about 72%, and we pay 28%. Those numbers change every year. COVID threw in some curveballs, but every year the federal government and the Centers for Medicaid and Medicare do a complex set of calculations based on poverty rates, and their share goes up and down, you know, a few points or a few tenths of a point, and that can have dramatic swings in terms of what the state share is. And everyone in Montgomery kind of holds their breath as those calculations are done in Washington. So our 28% share is around $719 million. That's actually not true, it's higher than that. But from the general fund, we spend about $719 million. So remember, our budgets are set up in basically 2 budgets. Education Trust Fund, which funds mostly education, preschool through higher ed, and the general fund, which funds everything that's not education. So of that, everything but education, 25% of that general fund goes to Medicaid right now. But notice that the other 2 line items, about another $700 million, actually slightly more than the general fund, That is covered by hospitals and providers themselves. We have a really unusual funding system in Alabama where we basically expect our healthcare providers to fund the system that allows them to provide the health. It's kind of a circuitous system of moving money around to shell game. And that's how we have figured out a way to pay as little as we can to fund Medicaid. Who gets Medicaid? So to qualify for Medicaid in Alabama, you must be low income and one of these criteria. Under the age of 19, pregnant, have breast or cervical cancer, legally blind or disabled, nursing home, or adult over 65 who can't afford Medicaid. And likewise, if you fall out of one of these categories, you lose your coverage. If you make too much money, you lose your coverage. If law's been changed, so you are covered during pregnancy and 1 year post-delivery, but 1 year and 1 day, you lose your coverage. So you can quickly fall on and fall off of Medicaid throughout your life and throughout the year. What do we mean by low income? Well, it's basically the poverty rate. So that means for a family of 3, about $33,000. For a family of 4, about $40,000. But really important to note that only the people in this family that meet these criteria get the coverage. So if your family is at or below $40,000, the children can be covered, but the parents are not, unless they are also pregnant, have cancer, disability, or what have you. So it's not the entire family, it's the certain people in that household. Unless there's one other program that we call parents and caretakers. So if you are the parent or the caretaker of someone who qualifies for Medicaid, a child or a senior or someone with cancer, you can also get Medicaid if you are very low income. So I showed to you what low income was, poverty rate, annual income of $33,000 to $40,000. Who would hazard to guess what the ceiling is to be very low income and qualify as a parent? Anyone hazard to guess?
18,000.
18,000?
About 3,000.
Oh, you're taking my thunder. $4,000 for a family of 3, $5,000 for a family of 4. Annual numbers, not monthly numbers. This has a lot of implications. This means that if you have a job, you basically make too much money for Medicaid. This means that if you work more than 11 hours per week at minimum wage, you make too much money to be on Medicaid. It also means that just because you are a minimum wage earner, that you are low income or unemployed or homeless, that does not mean you get Medicaid. And if you don't have children, you don't get Medicaid. So however you define that person who fits those criteria, they're not getting Medicaid in Alabama. Maybe some other states, but not in Alabama. There we go. So the jargon term is able-bodied adults with no cancer, no disability, no pregnancy, no children, don't qualify for Medicaid, no matter how much money they make. So you have no income, you're homeless, you don't get Medicaid in Alabama. So expansion. What's expansion all about? Expansion is about trying to close that gap. It raises the eligibility numbers from, in some cases, about 13%. If you're that parent of a low-income child, your cap is 13%. Or if you are just an individual with no children, it's 0%. Expansion raises that cap from as low as 0 up to 139% of the poverty level, allowing a much larger population of Alabamians to be eligible for Medicaid than are currently allowed to receive the coverage. This began back in 2010 with the Affordable Care Act. The federal government required every state to expand Medicaid. That was overturned by the Supreme Court in 2012. After that, it became optional. The idea, and I'll come back to this, the federal government puts a good amount of money into states to support hospitals that have a high number of low-income patients. And the idea was, the federal government said, we're spending a lot of money on this program. What we're going to do is we're going to scale that program back. And instead, we're going to put more Medicaid money into the states. So we'll take away this matching money and we'll expand Medicaid. So the states are made whole or better, and the patients are made whole or better. More people get coverage. Hospitals have an easier go of it. When expansion was overturned, what the Fed decided to do was go ahead and do the expansion for states that chose to expand, but also keep providing that additional money to the states. So hold that thought, we'll come back to it. So for the first few years, the federal government would pay 100%, then 95%, then 90% if you expanded Medicaid. So by last year, 38, 39 states had expanded, and by definition, a lot of those are Republican-led states. There's the map. It's basically the Southeast, Kansas, Wyoming, Michigan. Wisconsin. Wisconsin kind of has it, but it's kind of a backwards way to do it. Wyoming is planning to do it this year. That will leave Kansas, Texas, and the Southeast, who have not yet expanded Medicaid.
North Carolina just started the 1st of 2024.
Thank you. So 40. So this is that coverage gap. So a little bit hard to see, but on the theory of expansion was this, that if you are at or above the poverty line, up to about 400%, about $92,000 for an individual, then you could get insurance, if not through your employer, on the healthcare exchange that we heard so much about, and get some kind of subsidy. And the farther you were on this end, the less subsidy you got, admittedly. But down here, you got a lot of subsidy. So it was a mechanism for people at poverty level and above to get health care, to buy health care on the open market, in our context, pretty much from Blue Cross or maybe United, with a lot of support from the federal government. But when states did not expand Medicaid, what happened was created this gap in the middle. So we're now in a situation in Alabama and the other non-expansion states where if you are between, if you're an adult with no children, or if you're above 18%, if you're in this between 18% of poverty and 100%, sounds crazy to say, you are too poor to get a subsidy from the government. You need to make more money to get a subsidy here. Or you're too rich for Medicaid. So they're left out in the cold. And closing that gap was the entire idea of expansion. And I guess I glossed over that slide, but that would be about 280,000 people in Alabama in our estimation. About 280,000, mostly adults, could qualify for Medicaid if we close that gap. Most common objection, you've already seen it, we can't afford it. What the legislature said the first decade was we paid, and they were right. So think back, if you're a financial budget nerd like me and my colleagues, remember the general fund that funds for everything but education throughout the 2010s was constantly relying on one-time sources of revenue, like the BP oil settlement, or the tobacco lawsuit settlement, or some other sudden influx of money. Otherwise, we could not balance the books. So it was those one-off disasters that kept the general fund that funds roads and bridges and healthcare and prisons and whatnot, kept those books balanced. So not only could we not afford Medicaid, we couldn't afford anything else throughout the early and mid part of the last decade. However, things have changed, and that was the impetus of this study. Economics have changed, the law has changed, we now have when we began this, 35, 36 states have expanded. We have examples to look at. Have the numbers changed since we first began considering this back in 2014? So we launched this study with support of these foundations from around the state. Again, not really knowing where it would take us. I had a guess, and I was mistaken. We did this in partnership with Jackson State University up in northeast part of Alabama. And what we found, there's my slide, that expansion would add about 283,000 people to the rolls in the state. Different groups have slightly different numbers, but they're all within that same high number. Costs about $225 million. If you remember, we're paying $719 million now, so put our Medicaid expenses in the general fund up to about $1 billion a year. And that's a lot of money for a state like Alabama. So the question has always been, how do we pay for it? No matter how good an idea it is, no matter how good it is for us to get a big chunk of federal money, if we can't pay our share, how do we do it? And remember, the incentive for expansion was if we expand and we add these new people to our roll, we will not pay 28% like we're paying right now, we'll pay 10%. And the feds will pay the balance, the 90%. So it begins kind of a parallel track. So all those people in Medicaid right now will keep paying 28% for it. But all the new people coming in through this program, we pay 10%. And we bring down 90% of new money from federal government. But how do we pay for that 10%? Well, we found a couple of ways. First is the enhanced federal match. So as part of the COVID legislation, the federal government created a new incentive for these states that have not expanded. I guess North Carolina will benefit from this. And that is, if these non-expansion states will expand Medicaid, the federal government would increase their current share of Medicaid by 5 points for the first 2 years. So right now, we're paying about 28% of our Medicaid bill. If we expanded, the feds would increase that by about 5 points, and our rate would drop by about 5 points, 28 to 23, which is not a lot. But on a $7 billion program, that's a lot. And over 2 years, that generates about $620 million that we're going to pay right now. We're obligated to pay that. But if we expand, we would not have to pay that. We could do something else with it. Some lawmakers have floated the idea of setting up a Medicaid trust fund, putting a chunk of money into Medicaid, letting it grow interest so that we can cover the costs as the program goes. This would be a significant initial investment in that trust fund if we chose to do it. The second is cost shifting, and this is the phenomenal part. The dirty secret is that we are already paying a lot of healthcare costs for people that in other states would get Medicaid, but in Alabama they don't. That includes certain of the same populations, pregnant women who earn a little bit more than threshold, people with cancer. I'll hone in on people in prison. So if you are an inmate in prison and you need to be transported out of the facility to the hospital, we pay 100% of that cost out of our ADOC budget. And if you can go with the news, our prisons are in bad shape and are severely underfunded. But we're spending a good chunk of money to send inmates to the hospital. Were we to expand Medicaid, then the people in these criteria that we're right now spending state dollars on would be eligible for expanded Medicaid. And then we pay 10%. So again, think about the people in prison. We go from paying 100% of that cost to 10% of that cost. And I would hazard that ADOC could find something else to do with that money in corrections. Likewise, we're paying a good chunk of money for people with mental health and substance abuse through the Department of Mental Health. If we expanded, then a lot of those patients would be in Medicaid. We could free that money up for other uses within state budget and within, in that case, mental health. You look at all those numbers and all those populations, and what you come up with is, there again, we're shifting. We're going from paying up to 100% of costs down to 10% of costs. If you think there's a lot of math, I've got a slide deck on the SSUT, the Internet Sales Tax. It's a cracker. I can do that one next. $988 million that we would be able to save or reallocate over 6 years, spend in other ways. So you add that up with our fancy PARCA abacus, and what you get is this. If we expand Medicaid over a 6-year horizon, we're going to spend in state dollars general fund dollars, about $1.4 billion. But we reduce our expenses by almost $620 million, that incentive for the first 2 years, and another $982 million through cost shifting. And you sum that up, and we actually spend about $250 million less over 6 years, or can spend that money in different ways over 6 years. The interesting thing that this does not consider is that if you enroll, we know from the insurance industry that the earlier you get insurance and you get to see a physician and you get preventative care, you get healthier and your care gets cheaper. So if we enroll new patients, when we enroll you right now with cancer, you're an expensive patient. If we enroll you today, tomorrow, without cancer, and get you into a relationship with the doctor and can give you some preventative medicine, maybe that cancer doesn't develop as fast. We find it earlier. Your chance of living goes up, and the costs go down. Those are realities that we know exist, and they're not in these numbers. All right, but what that means is simply, sorry, my little box got shrunk. Expanding Medicaid means that we spend less on Medicaid to cover more people. So the economic impact, let me back up and belabor this point for a minute. The initial studies done by Dr. Becker at UAB and others, and my own guess, was that we would see economic growth, and the tax spinoff from the economic growth of Medicaid would eventually cover the costs. These numbers show that the program itself and the new incentives and the cost shifting covers the cost of expansion. And all the economic growth is gratis to the state and to our schools. So we project about $2.9 billion in economic growth annually, 20,000 new jobs, 15,000 new residents, increases in personal income and GDP. New jobs for both those with a bachelor's degree and without, so not just RNs and MDs. This is kind of hard to see, but these are represent different industries by income level, so lowest paying jobs, the highest paying jobs, and what matters is that all of them go up. So you see job growth across all levels of income. You see job growth, again, through all races and ethnicities. We see job growth for men and women. So the point of that is that the economic benefits flow broadly, not just to a select group of people who meet certain demographic criteria. Most important thing is that this would generate no new net cost to the general fund. So originally, the fear was we had to take money from the Education Trust Fund to fund Medicaid. Our analysis says, no, it would not require new money into the general fund. And more importantly, most new tax revenue, about $450 million, would flow into the Education Trust Fund. So a benefit for students and schools across the state as well. So, a slide I threw in here, and our administrators can speak to this more precisely. This is looking at the operating margins, how much basic money you made at the end of the year at the hospital level by states that have expanded Medicaid and those that don't. So between 17 and 19, all the hospitals had a less than a 2 percentage point margin, just barely above keeping meeting expenses. During the pandemic, it did pretty well. There's a lot of federal money coming in. It helped the hospitals during the crunch of the pandemic. July 2022, median operating hospital income for non-expansion states was a loss. And all the more so for small hospitals and rural hospitals. And for better or worse, healthcare in America is a business. And those of you who run businesses know you can't keep a business open no matter what it is when you've got a negative margin. So right now, rural hospitals are depending on Medicaid and those extra payments that are coming in to keep the doors open mostly. Remember I mentioned those extra payments the feds are giving. So right now, even though Alabama's not expanded, we're getting additional federal money for our population. At any point in time, in theory, that can go away. And if those incentives, support payments go away, and we have not expanded Medicaid, then we don't really have any more rural health care or small health care, and the larger health care system will be burdened by trying to serve the entire state. Quickly, some common objections. One, the rules could change. There's always a fear that the federal government could change that match, change it from 90-10 to something else. Yes, the rules could change. It would take a literal act of Congress. This is written into the law, not a rule. It can't be decided by the Secretary of Health and Human Services or by someone in an office. This would require passing both houses of Congress and the president to sign off on, which right now, none of that's going to happen. But when we've got 40 states, a good number of them Republican, I see it very unlikely that the Fed will change this 90-10 rule ever, quite frankly. Second, that if we expand Medicaid, it will disincentivize people to work. Studies have found just the opposite, that it actually enables people to work because you can get a job, you can work more hours, and not lose your health care. It's important to remember that we think about Medicaid as an entitlement benefit. It's not an entitlement benefit. It's a different kind of benefit. Unemployment puts dollars in your pocket. SNAP puts dollars in your pocket. TANF, which is called welfare, puts dollars in your pocket. Medicaid does not. So you can get Medicaid, but that will not help you buy groceries. It will not help you, get your kids enrolled in school. It's a different kind of program. So the incentive, the idea that you can work less because you have Medicaid is flawed. But to back that up, here are a whole bunch of studies from around the country that have found in different ways, in different phrases, different nuances, that states have seen no change in employment or increases in labor force participation, particularly for unemployed people, particularly for women, and particularly for people with disabilities. In one state, the percentage of people with disabilities working went up 6 points. So what states have found is that Medicaid expansion is a work incentive and allows employees to be more risky and work more hours, earn more money without losing health care. Third, the U.S. can't afford it, that we should not be spending money this way. That is a point worth arguing. That is a point that's already sailed. And California, Maryland, Washington are very happy that we are funding their Medicaid because we are paying for it in Alabama, but we're not getting the benefit for it. Not enough providers. This is true. There are not enough providers in Alabama to meet the healthcare needs that we have. But we have seen some evidence, particularly in mental health, and particularly in more rural areas, that expansion has created incentives for people to come back home to that state and provide care in that state, particularly in mental health. We have a lot of mental health providers in Alabama that don't work in Alabama because you can work through Zoom now. But other states have seen, like Kentucky has seen Kentucky-based mental health providers start working in Kentucky again because they can get a better reimbursement rate. And then finally, ideology. I've had a number of people who told me, lawmakers, we'd have voted for it if it had not been part of Obama's agenda. That's a whole different animal. So there are reasons to debate. There are ways to improve Medicaid, no doubt. This is not a panacea. If we expand tomorrow, it does not make Medicaid the end-all and be-all. Still a very sparse program. It doesn't cover a lot of things. We still need to think about how we can make it the best system it can be for our population. Our task was, can we afford it? And we found that, yes, we can if we choose to do so. Normally I take questions right now, but I think I'm going to save that for the moderated part at the end. And thank you for your attention.